Hi, my name is Dr. Frederick Meyer. I'm the Eline Professor and Enterprise Chair of Neurological Surgery at Mayo Clinic. I also happen to be the Dean of the Mayo Clinic Alk School of Medicine and the Dean of the Mayo Clinic College of Medicine and Science. Today we are going to perform a transnasal, transsphenoidal, endoscopic, microscopic resection of a ACTH-producing tumor in a young woman who has Cushing's disease. She's had an extensive endocrine workup. We're firm on the diagnosis. The trick in this patient, though, is that even though on MRI her adenoma is on the right, there's a second abnormality on the left, which raises the possibility that she has two separate tumors, or the right tumor is spreading along the front side of the pituitary gland to the left, which both of those cases would be unusual. So we're going to go to the operating room. Why don't you come join me and we'll get ready. So this young woman has Cushing's disease and is really quite ill from it. In this particular case, the MRI scan demonstrated a microadenoma along the right side of the sella, and therefore petrosal sinus sampling is not necessary. We felt pretty confident about the diagnosis of Cushing's disease and not Cushing syndrome. On her MRI, though, the tumor feathers from the right into the left, which emphasizes that, during surgery, because she's a young woman in particular, we want to really try to preserve the anterior pituitary gland in case in the future she wishes to have children. As we know, you can get children without a pituitary gland under the help of assistance of a good endocrinologist. But if you have a pituitary gland that's intact, it's surely much easier. Of course, we want to preserve the posterior gland to prevent diabetes insipidus. For me, we do this transnasal, transsphenoidal, with a combination of the endoscope and the microscope. Typically, my ENT colleague will use the endoscope. They're very adept and quick at it. Then I move the operative microscope in. The reason I prefer to use the operative microscope is it gives me two hands to do my operation quickly. I'll then use the endoscope to look around corners. But in that combination approach, we find that our pituitary surgery takes perhaps 70 minutes from skin to skin. It's quick, it's safe, efficient. The position for me is important. I like reverse Trendelenburg. The abdomen's been prepped out for some abdominal fat in case it's necessary. I like the bridge of the nose flat, parallel to the floor, pointed towards me about 30, 40 degrees so I don't have to torque and hurt my back. Feet straight to the other side of the room. And this gives a good working space for the ENT surgeon and myself to do what we need to do. We have the endoscopic monitor there, the operative microscope here, so whoever's working can see exactly what they want to see as they're performing the operation.
So I'm just inserting Afrin-soaked pledgets in the nose. It's just going to help with decongestion. I use a nasal speculum and a bayonet to just line them along the inside of the nasal cavity. I usually try to get 2 on each side. In terms of positioning of the bed, you usually try to keep the patient a little bit of reverse Trendelenburg, and then also you want the patient's head to kind of be at a comfortable height with your arms slightly bent. And then the monitor, you want to be about eye level height. Okay. And then we just let those sit for a few minutes just to allow time for decongestion. So right now I'm hooking up a 0-degree rigid endoscope. There are other options like 30-degree scopes, 45-degree scopes, 70-degree scopes, but a 0 is usually sufficient for this kind of surgery. You just have to remember to white balance your scope at the beginning of the case. So I've left these in for maybe 5 minutes, close to it, to let them decongest. 2 pledgets out of the right nasal cavity. Just taking a peek in here. She does have a pretty large septal spur here on the right side of her septum. Inferior turbinate, middle turbinate. I'm going to be injecting 1% lidocaine with epi, 1 to 100,000. And we'll inject the inferior turbinate. And the middle turbinate, and try to get a little of the axilla, and then try to get a little bit back here along the septum. So I think that the thing that might make this slightly challenging is that she has a large septal spur there along the septum, and that might make it a little bit difficult, especially if we were going to raise a longer nasal septal flap. For the purposes of this case, I think we'll be okay because maybe we'll be able to just drop our flap right along it. You want to make sure that you have adequate exposure and access to get back to the sphenoid os. And that's going to be medial and posterior to this. We're going to have to kind of lateralize the inferior turbinate and gently lateralize the middle turbinate, keeping in mind that it's attached to the skull base, so you don't want to forcefully fracture it over. Once you identify your superior turbinate in the back, then the sphenoid os should be medial to that. Once you identify your sphenoid os and open that, that'll give you access to the subsequent steps of your surgery. So now I'm gently pushing the inferior turbinate over. That's just going to give us a little bit more room to work. There's a very thin bone in there that you could just hear fracture. This is the nasopharynx back here. There's that large septal spur that we were talking about. And there's the middle turbinate. I'll take the freer. And gently move this over. The instrument I used to outfracture the inferior turbinate was called a Boy's elevator, and this is just called a freer. Again, I'm just trying to gently move this out laterally just so I can see back here. So that's likely the superior turbinate there. So I'll start looking for my sphenoid os just medial to that. I'll take the caudal. So there's the sphenoid os right there. So we should be in the sphenoid sinus. Keeping in mind that laterally and posteriorly you have the carotid artery, so you don't want to blindly just push into this. Can I get the straight sphenoid punch? I'm going to enlarge this opening just a little bit with a straight punch. More in an inferior direction, trying to get down to the floor of the sphenoid. You can come out here laterally a little bit too. Whenever possible, you want to avoid stripping some of that mucosa, otherwise it'll bleed. And we're able to kind of see, get a better look into that sphenoid sinus now. I'll take an afferent soak pledget. If you run into any bleeding and you feel like you can't see well, it's worthwhile sometimes just put a pledget in there and let it calm down. It's important to suction out your nasopharynx too intermittently, because that kind of serves as your reservoir for drainage of blood. That way it doesn't just keep pooling up in the nose. You obviously want to be careful when you're putting your instruments in and out of the nose. You want to cause as little mucosal trauma as possible, because the more blood that you have, the harder it is to see, and also the darker your screen gets. The blood will kind of absorb a lot of the light. Okay. So now things have settled down a little bit for us. We have a nice wide opening there into the sphenoid os. So now we want to raise the nasal septal flap. Depending on the type of surgery and the type of skull base coverage that you might need, if you're concerned about a CSF leak, you might raise a longer nasal septal flap along the septum. For this case specifically, we're just going to raise a very short one and bring it straight down. We're going to try to basically start at the top of the sphenoid os here and then bring it down towards the floor. You can do this a couple ways. You can do this with a caudal elevator, or you can, some people use a needlepoint cautery to make their cut along here. And once you feel like you're through the mucosa and you're in a submucoperichondrial plane, you can start working it back. The caudal sometimes isn't as elegant or efficient to get through the mucosa. So at the moment, it's a little bit of a tough angle to get the mucosa off with the caudal. So I'm just completing my cut here with these Bellucci scissors. Caudal again. We're just working our way back along this submucoperichondrial plane here. Bellucci scissors. So we're almost back to where we need to be. There's one little band of mucosa that's still hanging us up. One of the pitfalls here is if you don't release this mucosa from its attachment within the sphenoid, you can get hung up here, which is where we're hung up at the moment. Bellucci scissors. You just want this small nasal septal flap to drop down so you can roll it into your nasopharynx. Alright. So again, just kind of bringing this down off the face of the sphenoid here. Eventually we'll see the sphenoid rostrum. So again, this is a very small nasal septal flap. It's mainly just dropping it down so we can get access to the posterior septum back here. Okay, I'm pulling the pledgets out of the other side of the nose right now. That's just going to allow me to fracture over the septum without getting any resistance. So you want to kind of see where it's giving you a little bit of a bend here. And there we go, fractured right over. So you don't want to go through the mucosa on the other side. You just want to keep raising that up like we did on the other side, staying submucoperichondrially. You can do this with a freer or a caudal. I still have the caudal in my hand, so I'm continuing to use that. Now what we're looking for on this opposite side is the contralateral sphenoid os. We just keep working this laterally. Suction. And there we can see the contralateral sphenoid os right there. I'd like a little more freedom if we can get it. I'm just using a straight through cut to remove a few of these pieces of cartilage that are hanging out. So we've got a decent start here. So just kind of recap and reorient. That's the contralateral sphenoid os. This is our ipsilateral one. So we started with our exposure on the right. We've swept down some of the mucosa here on this side off the septum. We have some of the posterior vomer here, which is going to attach to the sphenoid rostrum. So now we're going to take a kerrison and make a connection superiorly here. And the goal of this is just to free up this rostrum as much as possible so that when we go to fracture it and take it out, it's free. So it looks like we got a pretty decent start. You can see we're pretty well freed up above the bone now, above the cartilage. So now we need to make cuts down here and down here so that we can get this piece in the middle out. And then again, you just want to be careful you're not grabbing any of your mucosal flap on this side. You want to engage it within the sphenoid sinus and kind of pull back a little bit. And same thing on this side. Don't grab your nasal septal flap. So I'm basically on the floor of the sphenoid here. It's hard to get much purchase to get any more bites here. And same on this side. So that's about as low as we can take that. So next, if you feel like you're pretty well freed up top and you've got good down biting cuts, you can take a Ferris Smith and then you want to try to grab this at its base and gently twist it and get it out. So, and this appears to be the intersphenoid septum, which appears to be going back and to the left on this patient. You don't want to just blindly fracture the intersphenoid septum because a high percentage of the time it actually attaches to the carotid and you could cause a dehiscence there and cause a carotid bleed. So I'm just gently trying to bite this back. As you can see, we have a much nicer view now of our sella. This is a Takahashi that I'm using to try to get a little more of this sphenoid rostrum off. So now I'm going to try to use a 45-degree through cut just to see if I can get a little bit more of this down out of our way. We're very close to being where we need to be at the moment. And again, I'm just taking little bites of this intersphenoid septum because I don't want to take a big bite or avulse it. So before we take one last look before bringing the speculum and the microscope in, I'm just going to put these pledgets in to dry things up. Just checking out our other side, looks like no holes in our flap. So now we got a fairly good look at our sphenoid back here. That should be the sella. Out laterally, it's hard to see them with the 0-degree scope and because our exposure is not very wide, but you would be able to see the opticocarotid recess. So some people will dilate the nasal cavity a little bit with this before they put the speculum in to see if they can get themselves a little bit more room. This nasal speculum typically put in upside down this way. It's usually a fairly tight fit. You want to track a path back to the sphenoid and have a good angle towards your sella. And that's the exposure that we'll be working with for the case. And certainly if it ends up being suboptimal, we can always take a little bit more bone out laterally or superiorly.
So we have a very nice exposure of the sella. This is the patient's left side. That's the right. In the midline, we've confirmed verbally whether our ENT surgeon is right about here. In a thick sella, there's some abnormal bone in the sphenoid or the junction of the clivus with the sella that we'll leave alone. And we can see, and I can feel the planum, frontal planum right up there. So as we all know, there'll be a left carotid over there, a right carotid way over there. So we're going to start right there in the midline. And I usually like to confirm verbally with my colleagues that this is indeed the midline. So do we all agree that this is midline?
Yes, sir.
Okay. So when taking off the sella floor, there's so many different ways you can do it. Honestly, I tend to start this way to see if I can just sort of, chip it off a little. If I can't, then I could use a chisel or a high-speed air drill with a diamond burr. In kids, sometimes the sphenoid sinus is pneumatized, where the bone's really thick and you have to drill it off, and then I find stereotaxis quite helpful. If you decide you have to drill it off, then I would suggest using a angled Midas Rex type of drill with a angled head, so you can see it with perhaps a 3mm diamond burr. So I'm not making great progress here by chipping it off, because her cell floor is a little flat, it's not terribly convex. So at this point then we will use the chisel, a little more barbaric, but certainly effective, and if that doesn't work well, then we'll just go ahead and pull up a drill. So I guess what's sort of nice about this is you get to see all different approaches to how to take the cell off. This is old-time neurosurgery, but it works pretty well. Looks like we'll be okay. All we have to do is get a little ledge out so we can get an angle kerrison in, which I think we're going to do. There we go. In Cushing's patients, it's common to find a large circular sinus. In fact, we can see some discoloration there. Can I have the small angle kerrison now? So I think it's very helpful to get a broad exposure, especially for microadenomas, which tend to be lateral. But you don't want to be dangerous. You always want to be mindful of where the carotids are. Now we know that her tumor, we think on MRI, is on her right. So we want to make sure in particular that we have good exposure there. But as I had commented earlier, her MRI is a little unusual where there appears to be some extension of this tumor across the midline. So I really do want to have a good exposure. Very rarely you can find a patient with multiple microadenomas. So that's looking pretty good, the angle kerrison. You can see there's some venous channels in the dura, so we can anticipate that there'll be some bleeding as soon as we open the dura. That will work around. So I feel pretty comfortable where the midline is, and I'm not really worried about the carotid, but a very useful tool is this microdoppler. And if you have any question, it's worth just listening for a moment to make sure you're not running into the carotid artery. So there's a safe entry zone. I can hear the carotid on the left, just barely, but right there will be just fine. So I would suggest that if you're unclear about the anatomy, angle kerrison, then stereotaxis is very helpful, stereotactic CT or MRI. And if you're in the surgery and you don't have that and you're worried, take a step back and just get a microdoppler and listen for a moment. So we will go ahead and make a incision in the dura. We agree this is midline?
Yes, sir.
Okay, so we'll make a small little sit. And as we predicted, there's going to be some bleeding because we know there's sinuses. Sometimes I'll do a subdural dissection with a little blunt ball tip dissector like that, because it's like popping a pimple. Punch, and there's the adenoma. So that's the adenoma. That worked pretty well, the subdural dissection, didn't it? Mm-hmm. When you have Cushing's disease, the pituitary gland can have something called Crookes changes, which can be sometimes hard to distinguish visually from an adenoma. But that looked pretty convincing to me. So I'd sure like to get some pathologist specimen there. So there's some bleeding from the dural edge that I'm not terribly concerned about. If you look through the ring, that's the normal gland. It has that pinkish color to it. So again, since she's a young woman, it'd be nice to take out the tumor, preserve the normal gland. That's posterior gland there. See that whitish there? I don't like to see that too much. So you can actually see the separation between the anterior, the other curate, please, the anterior and posterior pituitary gland. There's a cleavage there. I'll get a little, can I have the small punch? So that's normal gland. There was a little discoloration down there, which I think was posterior gland there. That might have been the abnormality we saw. As you might recall, there's the posterior gland. It's sort of a white, looks like oatmeal. You'll notice when I use that instrument on, I push the normal gland away so I don't burn it, bipolar. Sometimes if you can get a bipolar in, it's very helpful. And so I sort of feel obligated to look a little on that side because I thought we saw what might have been a second adenoma. And I must confess, that looks like that's that, isn't it?
Yeah.
Punch, please. So this patient either had two tumors or her Cushing's, why don't we send that off, had extended across midline, which would be unusual. Yeah, but you can see for yourself that when we open the dura, there's an obvious tumor on her right, but in fact, I found something over here, right? And that's not posterior gland. So that has to bother us, right? to have two tumors. I mean, I think this is probably that, quite frankly. There's the posterior glands way back there, whitish, bipolar. So that's a little distressing, actually. She had either one unusual microadenoma or two separate tumors, bipolar. So that pathology we just sent off would be from the left side. It's unfortunate I did not get good path from the right side. So you can see the normal pituitary gland is coming out, right? Mm-hmm. Can I have the other curette? Of course, when you heavily cauterize the dura, as I was doing, it contracts away from the bone, and sometimes that just stirs up more bleeding, right? But you always try anyway. So looking through the ring, we can see posterior gland, there's white. The anterior gland is pink. I think you can see very nicely the differences between the two. We have a small punch. We have the anterior lobe is divided into two, it seems. Part of it hanging down. There's no CSF leak. And probably we're close to being done here. We'll try one larger ring curette. I doubt I'll be able to get it in, but we'll try it anyway just to see if we can. Oh, there we go. Just to make sure we've gone all the way over lateral, which was our primary target. I think I'm pretty happy there. I don't think we should do much more. So with that being said, could I have some gel foam, please? So there's no CSF leak. There's no need to put any fat in. And now if we just put a little gel foam right in the tumor evacuation site, that will cause the dura to compress and stop our venous bleeding without any problem. If there was a CSF leak, we probably would put some fat in, maybe some fibrin glue, maybe ask our ENT colleagues to put a mucosal flap in. But none of that is necessary here. Sometimes I'll take some nasal cartilage and put it subdural. Sometimes I'll take a piece of bone and carve it out and put it like that across. Although some of our ENT surgeons don't really appreciate that maneuver and they worry that it could be a source of infection. And so I usually ask my ENT colleague if they have any preference, and if they do, then I won't do that. I happen to know that this ENT surgeon probably prefers that I not do that, and hence we won't. So now we can call our ENT surgeons to close. Thank you.
The neurologic surgery team has finished their portion of the procedure, and the ear, nose, and throat team has come back in to close. I'm going to remove a small bone chip which can generate crusting during healing. Remove blood products from the sphenoid sinus and place a little bit more gel foam over the defect. This is packed loosely in the sphenoid sinus. We then locate the nasoseptal flap that was raised at the beginning of the procedure and do our best to cover any exposed bone of the septum. We ensure that the nasopharynx is still clear so the patient has an adequate nasal airway. We then gently remedialize the middle turbinate so that it does not scar off the maxillary sinus. And we again place gel foam in the middle meatus to ensure that the middle turbinate does not lateralize. We also place gel foam between any areas of exposed bone and mucosa so that the patient does not get a synechia or a scar band. And then finally, the nasopharynx is suction clear of blood and irrigation. We always check on the opposite side. Suction the nose clear. And that completes the procedure.